So hello all, and please, please, please ask questions now, or if I have my email at the end and I've already emailed with a bunch of you. And if I don't know the answer, like there was a bunch of dental questions, I found a dentist who could explain to me something, so I can find people if I don't know the answer. Okay, so I want to thank you all because you are the people that did this study. I mean, I asked the questions, but you have provided all the information. And this paper is in, I think, review right now at a journal. But we were able to collect with Mrs. Nye and the TESS Foundation and all of you 23 patients. And move this out of the way. So many of you or probably all of you on this are involved in this study. And the nice part was we were able to get patients from 3 months to 29 years. So that's a big age range, and it gives us a little bit of a sense of where patients are across the spectrum of ages. I think 29 years is one of the oldest patients identified to date with this disorder. So I'm going to go through in slightly more detail different things about epilepsy, so seizures. I'm going to focus on that, and I'm going to focus on the EEG, and then I'll try to wrap everything up, but please feel free to ask questions as I go. As everybody here probably knows, the onset in 98% of the kids was within the first week of life. I'm a little suspicious the one person that wrote that they had seizures starting in the first year of life, maybe they were just not picked up, but by far the majority of kids have seizures within the first week of life. 3 of you sent me long EEGs that I was able to review, and basically all of the kids were having a lot of seizures, many seizures per hour. Each seizure was short, lasted a minute, but they were very frequent. And many of you sent videos with them, so I was able to see the nurse standing next to the bed, and I could see the seizure, and the seizure was happening and the nurse was not noticing anything. So even though some of the seizures were obvious clinically, many of them were not, and that seems to be the pattern. So I think it's important to have that long EEG during that first few days of life, which is now pretty much standard of care in the United States. I don't know as much about around the world, but a long EEG can pick up seizures that were not being detected by the person taking care of the child. This is a picture, a graph that shows all the different seizure types you reported to us. We used kind of a mixture of doctor talk and patient talk to try to describe each seizure. But what you can see is that by far the majority of patients had something called a generalized tonic-clonic seizure, which is, Mrs. Nye showed a picture of Tessa having one, where you get stiff and then you shake. The other seizure types were kind of mixed, but most of them had some kind of movement in them. So any of these seizures that you see here, focal motor, abnormal motor, unresponsive, myoclonic is body jerking, tonic is a stiff seizure, those all have movement. There was 3 patients described as having absence seizures, which we were taking to mean that they were staring seizures without motor, but that was actually very rare. So at least it seems in this disorder that the seizures that you're seeing motorically are the seizures that they're having. People have not picked up subtler seizures on video EEGs or things like that, and I was able to review quite a few video EEGs from different patients, and that was the general appearance, is that they are mostly motor seizures, which is nice in a way because then you can feel assured that the movement that the kids are having, where you're not positive if they're seizures, are probably not seizures. This is, I think, one of the take-home slides, which is that there is a huge spectrum of seizure frequency. So there was one patient, and only one patient, who was seizure-free off of medications. I don't know what that means for the rest of you, but my sense is that probably being seizure-free off medications is not likely to work. But it does at least suggest to me that the seizure severity, it can be milder in some kids. Now, it goes all the way to daily seizures. So you can see that some of the kids were having multiple seizures per day. And I'm going to talk a little bit about the medications that people were on at the time we asked. And I want to point out that if your child is having daily seizures, it is likely that there could be some medication adjustments that might help them. So keep that in mind, that some patients can be seizure-free, which probably means the disorder is not untreatable, I guess is what I'm saying. You may have to keep working at it, but I think it's worth trying to keep adjusting the medications if you're having frequent seizures. These are the medicines that everyone told us about. And the blue bar is how many patients are taking that medication at the time the survey was being asked. And what you can see that phenobarbital and valproic acid, phenobarbital doesn't really go by another name at this point, but valproic acid goes by many names around the world. It often has the word Depakote, Depakine. I'm trying to remember what it's called in some other countries, but those were the two medicines that not only were being used, were being used in the most patients, but interestingly, it also had the highest rate of seizure freedom. So the orange bar shows the number of patients taking the medicine that were seizure free. And you can see that about half the patients taking phenobarbital and about half the patients taking valproic acid were in fact seizure free. I'll tell a little anecdote about Tessa, if you don't mind, Miss and I.
Yeah, go for it.
Okay, so I've taken care of Tessa for quite a while now, and she had just terrible seizures, just constantly having myoclonic seizures. And Mrs. Nye had given me a list of meds she'd been on in the past, and she had failed. And one of those was valproic acid, which she'd, I think, actually been on twice without success. And recently, about 9 months ago, maybe, we added back valproic acid because I was kind of out of ideas. She'd been on everything available in the United States. And lo and behold, she's seizure-free on valproic acid, which had not worked in the past. So I guess I'm not saying you have to try valproic acid. What I'm getting at is a medication that maybe didn't work at a certain developmental stage, or maybe it's something to do with the combination of meds she's on, has actually made her seizure-free. So I think take hope from this, that if your child is still having seizures, there may be a cocktail of medications that will work, even one that didn't work in the past, amazingly. The only other thing I'd like to point out to you is that acetazolamide is not a typical seizure drug. We don't use it a lot for seizures. It's a diuretic. It goes by the name Diamox. Sometimes people call it that. And it causes your kidneys and your brain to change the way it handles fluid a little bit. And all I can say is that it would not be a typical seizure med, and it seems as though a lot of patients are on it, which probably means they find some benefit to it. So it might be something that if your child is not on it, you might talk to your doctor about it and ask them what they think about it. All the other medications are varied quite a bit. They all have different mechanisms of action. And at this point, I don't know what to say. Keppra, which is levetiracetam, is another one where a fair number of people were on it and were seizure-free. So I hope that you will find a cocktail that works for your child, so keep looking. And I'm happy to send this to anyone, so if they want to take it to their doctor, they can do that. And hopefully the paper will get published so their doctor can look it up. Okay, so I want to talk a little bit about EEGs. I think this is actually probably very exciting and hopeful for you all. So this is an EEG from my office, and what you see is that it's measuring the brain wave activity, so how fast the neurons are talking to each other. And this is actually a normal EEG. The letters demonstrate where in the brain we're measuring the activity. The odd numbers are the left side of the brain. The even numbers are the right side of the brain. And what you can see here, if you sort of go with me, is in the third second on the page, so each of these little hashtag lines is a second, that there's a blink. So you see that big deflection? I don't know if my cursor is showing up, but that is a deflection, that's a blink. So when your eyeballs blink, they move and they have some electrical charge in them, so you can see that blink. That gives you a sense of like that it's picking up normal activity. But the organization is beautiful in this EEG. So the front of the head is a little bit less wavy. The back of the head, so at 01 is the occiput, the back of the head, and that goes up and down a whole bunch and quite frequent. And that's normal. You should have that. That's a sign that the connections between the neurons are working well, they're there, everything's intact. So when I started reviewing, I think I reviewed 58 EEGs in different children with SLC13A5. I found, oh, I'm sorry, this didn't blow up very well. I found, and you're not going to believe me based on this very poorly shown video, but what I found was that the kids, while they're having seizures, this is a seizure over in the right hand corner, the background is actually normal. So even in, I think, a 26-year-old, I was able to look at the background of the EEG, and in wake and sleep, it appeared normal. Well, what does that mean? It doesn't mean that they're not having epilepsy. It just means that I think that the brain is intact. There's still connections that are there that should be there, that they can work at least some basic level correctly. And I think that holds out a lot of hope that this is not a neurodegenerative disease, meaning that the kids will get worse with age. I think it means that this gene therapy idea may have a lot of traction if we can at least fix part of the underlying process. The rest of the brain is present in enough, in a good enough way that maybe it will be able to be rescued. I'm a scientist, so I don't want to get your hopes up too high, but I think it's a good sign. So the take-home message I really wanted to give you on epilepsy and EEG is that the seizure types, severity, and frequency are not homogeneous in the older kids. In the infants, they really seem to be. They have very frequent seizures, and they last about a minute or two, and they occur multiple times per day. But as the kids get older, their seizure type, severity, and frequency are not homogeneous. And while only one patient was able to be seizure-free off medications, that does hold out hope, I believe, for the other kids. And so we shouldn't give up. We should keep looking for a cocktail of medications that work. The most exciting thing, I think, from what I've been able to get data from you all is that the normal EEG background really suggests to me that the cognitive and movement issues that you're seeing is not due to seizures or abnormal epileptic activity on the EEG. The kids do have sharps, which are a marker for seizures, but they are not so frequent or so severe that I think they're causing all the movement problems that you're seeing. So that, of course, means that if you get the seizures under control, you're not going to improve those things. However, it also means that the brain is pretty much intact, I'll say that, and that the wiring is all in place, and we just have to somehow figure out why the lack of SLC13A5 is causing a problem with the way the neurons are working. It also raises the problem that I think seizures and EEG are not the best markers of disease for a clinical trial. Kim's gonna talk about the natural history study idea, and I think that what you want in a natural history study is something that is a very good marker of the disease. And if only about half the kids are having frequent seizures, we can't really use that as the best measure for treatment success. So These are some of the disease markers that I think will be helpful. As you all mentioned, movement and motor skills, and now hearing you all talk about sleep, I think I should add a sleep component, so I'll go back and look at that. But most of you said that there were movement and motor skill problems, language skills, and then something we called adaptive behavior skills, which really incorporate the movement and motor and language skills on a daily basis. So how do these things impact your daily activities? These are some data that we collected from you all on something called the Vineland. And this is across the bottom here, 0 to 200 is the months of the child in age. And then the Vineland scores for motor. So these are things like, how does your child pick up something? How does your child feed themselves? All of those kind of things. And what you can see is that in motor skills, the kids continued to make progress. So Maureen, when we first got on the call, mentioned that her son just learned to walk recently. So that sort of, does demonstrate this concept that as the kids get older, they will continue to gain skills for the most part. It's slow, so these scores are low. They should be much higher for these ages, but it's an upward slope. So over time and with increasing age, they continue to gain skills. This also supports the concept that this is not a degenerative condition. It really is a condition where they just are slow to gain skills. Here is maybe a picture of Tessa running.
Good job, good job, good job, good job, good job.
And what you can see is that she has a unusual kind of running style. It's sort of wide, and she swings her arms out to try to balance herself. So this was a study I started to do with the Rett. Rett is a different disorder rating scale, and I discovered that that rating scale was not helpful. So she was at the top end of it. So we had to come up with a different rating scale. Oops, sorry. We've developed a motor movement speech video rating system. And you all, if you're willing, can take part in this. This does not require you to be in the United States. This does not require you to be in your doctor's office. We can walk you through this. This has been used, at least part of it has been used in a different disorder from some of my colleagues at Stanford. And they have been doing this successfully for about a year, helping patients from all over the world. They can walk you through it. And it's a video. So every child is video doing certain tasks. Not all children will be able to do these tasks. They're not very intense tasks as far as the child does not need to cooperate, I guess is what I'm saying. We've done it with Tessa and Colton. They did well. I was able to score it. It was pretty straightforward. And I'm told that if you do it a couple times, the kids get better and you get better at doing it. And it shouldn't take, we think, more than a half an hour, but it may the first time take a little bit longer. We have a scoring system for it. And I think this will probably be the most important outcome measure for any kind of clinical trial going forward, but we need to prove that. This is still in the kind of work in progress stage. Okay, I wanted to talk a little bit about language. So sorry, these are kind of weird. The developmental age is in years. So if you look at this, the best kid had a developmental age of about 3 years of age. And the bottom is in months. So you have to kind of get in your head that a 3-year-old is 36 months. So a 3-year-old is way over here. So none of the kids, at least for language, were much beyond 3 years of age. Now, their receptive language, the blue bar, the blue dot, sorry, is much better than their expressive language, which I think from meeting Tessa and Colton and seeing them frequently, that is very true. the kids understand way more than they are able to express. And I think part of that is they have a lot of impairment in their mouth movements and mouth control. But again, in general, the curve is going up. So as the kids get older, they learn more. And so we do have a test that we can do on that. That is not as easy to do remotely, sadly. So we will continue to do these adaptive behavior measurements for language, but the kids that we will actually see in person will do a little bit fancier test. I'm gonna maybe defer this because Kim's gonna talk about natural history studies and explain what they are. But the basic idea is everyone on this call is gonna be allowed, and we really want you to participate in a natural history study where we look at things that I think will be good markers for the disease that could then be used to say whether a therapy is working or not. These are very basics of the study. We'll do things like, we'll get an EEG to confirm what I've seen in the EEGs that you sent me. We'll keep a seizure diary. We're gonna focus on things like motor and language. Labs, these are things that you can all think about, and motor and rating scales and caregiver quality of life. Thank you, thank you, thank you. Okay, I think, is Kim next, or do you want to ask questions?
I think let's say ask questions at the end, just in case people have to go. At least we'll deliver all the information, and then we can have this go over time on the questions.